Okay, this is a recording for the Final Frontier Npte Day 29, March 7th, 2020, Saturday. Reviews skeletal and soft tissue conditions and lower extremity conditions. The first condition is osteoporosis. For this video, I'm just going to read the therapy ed pages that they provided here. But I am eventually going to take all of those diagnoses that are listed in this therapy ed pages, and last night I went ahead and listed all of them here. And so I'm going to do a video focusing on each one of these, or most of them, like osteoporosis, osteomalacia, osteomyelitis, and so that way we can study a little bit more in differential diagnosis. Okay, so skeletal and soft tissue conditions. Osteoporosis, a metabolic disease that depletes bone mineral density mass, predisposing individual to fracture. It affects women 10 times more frequently than men. Common sites of fracture include thoracic and lumbar spine, femoral neck, proximal humerus, proximal tibia, pelvis, and distal radius. Primary or postmenopausal osteoporosis is directly related to a decrease in estrogen production. Senile osteoporosis occurs due to a decrease in bone cell activity secondary to genetics or acquired abnormalities. Medications: calcium, vitamin D, estrogen, calcitonin, and biphosphonates. Diagnostic tests utilized: a CT scan to assess bone density, single and dual photon absorptiometry are also used, but very expensive. Clinical examination will assist in confirming diagnosis. Physical therapy goals, outcomes, and interventions. Bone joint protection strategies. Maintain and improve joint mechanics and connective tissue functions. Implementation of aerobic capacity endurance conditioning or reconditioning, such as aquatic programs. Patient-client education on dietary changes to improve mineral intake. So again, this is the book. I'm going to be doing a video just on studying each one of these diagnoses. You see metabolic disorders, they're categorized by types of pathology. Metabolic disorders such as osteoporosis, osteomalacia, and Paget's disease. And then in chapter 25, you have infectious disease of the musculoskeletal system such as osteomyelitis. That one I for sure saw on the list. Oops. Wrong one. Here we go. Osteoporosis, osteomalacia, osteomyelitis. Yeah. So, anyway, FYI, be looking for that video if you're interested. Moving on. Osteomalacia, characterized by decalcification of bones due to vitamin D deficiency. Symptoms include severe pain, fractures, weakness, and deformities. Medications: calcium, vitamin D, and vitamin D injections in the form of calciferol. vitamin D2. Diagnostic tests include plain films, lab tests, urinalysis and blood work, bone scan, and bone biopsy if warranted. Clinical examination assists in confirming diagnosis. Physical therapy goals, outcomes, and interventions include joint bone protection strategies, maintain and improve joint mechanics, and connective tissue functions. Implementation of aerobic capacity, endurance, conditioning, or reconditioning, such as aquatic programs. Go ahead and make this. Okay, osteomyelitis, an inflammatory response within bone caused by an infection, usually caused by staph, but could be another organism. More common in children and immunosuppressed adults than healthy adults. More common in males than females. Medical treatment consists of antibiotics. Proper nutrition is important as well. Surgery may be indicated if infection spreads to the joints. Diagnostic tests utilized include lab tests for infection and possibly a bone biopsy. Clinical examination will assist in confirming diagnosis. Physical therapy goals, outcomes, and interventions. Bone joint protection strategies and cast care. Maintain and improve joint mechanics and connective tissue functions. Myofascial pain syndrome, characterized by clinical entity known as a trigger point, which is a focal point of irritability found within a muscle. Trigger point can be identified as a taut, palpable band within the muscle. Trigger points may be active or latent. Active trigger points are tender to palpation and have a characteristic referral pattern of pain when provoked. Latent trigger points are palpable taut bands that are not tender to palpation, but can be converted into an active trigger point. Onset is hypothesized to sudden overload, overstretching, and or repetitive sustained muscle activities. Medical intervention may include dry needling, intramuscular manual therapy, and or injection of analgesic, possibly combined with a corticosteroid. Diagnosis is made by clinical assessment with no diagnostic test available. Clinical examination will assist in confirming diagnosis. Physical therapy goals, outcomes, and interventions. Implementation of flexibility exercises to maintain, improve normal joint motion and length of muscles. Implementation of manual therapy for maintenance of normal joint mechanics. Soft tissue massage techniques and joint oscillations to reduce pain and or muscle guarding. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Use of spray and stretch technique, utilization of dry needling, cryotherapy, thermotherapy, hydrotherapy, sound agents, and TENS for symptomatic relief of pain. Desensitization of trigger point with manual pressure, implementation of strength, power, and endurance exercises, active assistive, active and resistive exercises, task-specific performance training. Tendinosis and tendinopathy. Common tendon dysfunction whose cause and pathogenesis are poorly understood, but likely related to degenerative collagen changes within the tendon, often referred to as tendinitis. However, there is no inflammatory response noted. Common in many tendons throughout the body: supraspinatus, common extensor tendon of elbow, patella, Achilles tendon, and gluteus medius. Histological characteristics include hypercellular hypervascularity, no indication of inflammatory infiltrates, and poor organization and loosening of collagen fibrils. Medications include acetaminophen, NSAIDs, and/or steroid injection. Diagnostic test utilized is possibly the MRI. Clinical examination assists in confirming diagnosis. Specific special tests are available to assist with making diagnosis within each region and joint. Physical therapy goals, outcomes, and interventions. Implementation of flexibility exercises to maintain improved normal joint motion and length of muscles. Implementation of manual therapy for maintenance of normal joint mechanics. Soft tissue massage techniques and joint oscillations to reduce pain and/or muscle guarding. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Endurance and strengthening exercise with initial emphasis on eccentric phase of exercise. Aerobic capacity endurance conditioning or reconditioning. Application of thermal agents for pain reduction such as cryotherapy, thermotherapy, hydrotherapy, and sound agents. Patient education and training for instrumental activities of daily living, as well as activity modification to decrease further tissue damage. Household chores, yard work, shopping, caring for dependents, and home maintenance. Bursitis. Inflammation of bursa secondary to overuse, trauma, gout, or infection. Signs and symptoms of bursitis include pain at rest. Passive range of motion and active range of motion are limited due to pain, but not in a capsular pattern. Medications: acetaminophen, NSAIDs, and/or steroid injection. Client examination assists in confirming diagnosis. Physical therapy goals, outcomes, and interventions. Flexibility exercises to maintain improved normal joint motion and length of muscles. Manual therapy for maintenance of normal joint mechanics, soft tissue massage techniques, and joint oscillations to reduce pain and/or muscle guarding. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Aerobic capacity endurance conditioning or reconditioning. Application of thermal agents for pain reduction, edema reduction, and muscle performance. Cryotherapy, thermotherapy, hydrotherapy, and sound agents. Patient client education and training and retraining for IADLs, household chores, yard work, shopping, caring for dependents, and home maintenance. Muscle strains. Inflammatory response within a muscle following a traumatic event that caused micro tearing of the musculotendinosus fibers. Pain and tenderness within that muscle. Seen within muscles throughout the body. Medications: acetaminophen and/or NSAIDs. Diagnostic tests utilize MRI if necessary. Clinical examination will assist in confirming diagnosis. Physical therapy goals, outcomes, and interventions include flexibility exercises to maintain improved normal joint motion and length of muscles, manual therapy for maintenance of normal joint mechanics, soft tissue massage techniques, joint oscillations to reduce pain and or muscle guarding, biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Aerobic capacity, endurance conditioning or reconditioning, application of thermal agents for pain reduction, edema reduction, and muscle performance, such as cryotherapy, thermotherapy, hydrotherapy, and sound agents. Patient-client education and training for IADLs, household chores, yard work, shopping, caring for dependents, and home maintenance. Myositis, ossificans. I hate saying those words. Painful condition of abnormal calcification within a muscle belly. Painful condition of abnormal calcification within a muscle belly. Calcification. Usually precipitated by direct trauma that results in hematoma and calcification of the muscle. Can also be induced by early mobilization and stretching with aggressive physical therapy following trauma to muscle. Most frequent locations are quadriceps, brachialis, and biceps brachii muscles. Medications, acetaminophen and or NSAIDs. Surgical care is warranted only in patients with non-hereditary and only after maturation of the lesion, 6 to 24 months. Surgery is indicated when lesions mechanically interfere with joint movements or impinging on nerves. Diagnostic tests utilized, imaging, plain films, CT scan, and or MRI. Clinical examination assists in confirming diagnosis. Physical therapy goals, outcomes, and interventions include flexibility exercises. Avoid being overly aggressive with muscle flexibility exercises, which may worsen the condition. Manual therapy for maintenance and normal joint mechanics. Avoid aggressive soft tissue massage techniques, which may worsen condition. Biomechanical faults caused by joint restrictions. Aerobic capacity, endurance conditioning, or reconditioning, such as aquatic programs. Complex regional pain syndrome, CRPS, formerly referred to as reflex sympathetic dystrophy, RSD. Etiology largely unknown, but thought to be related to trauma or a precipitating event, which can be multifactorial. Can affect upper and lower extremities, trunk, head, and neck. Results in dysfunction of sympathetic nervous system to include pain, circulation, and vasomotor disturbances. Physical therapy outcomes and interventions include patient-client education for injury prevention and reduction. Desensitization activities that focus on return to work, home, school, and activities. Flexibility exercises. TENS, electrical stimulation TENS for pain relief. There are two types of CRPS. One, CRPS 1 is frequently triggered by tissue injury. The term describes all patients with the above symptoms, but with no underlying nerve injury. Patients with CRPS2 experience the same symptoms, but their cases are clearly associated with a nerve injury. Mechanical intervention may include sympathetic nerve block, surgical sympathectomy, spinal cord stimulation, intrathecal drug pumps. Medications include multiple forms, including topical interlesion drugs that act locally on painful nerves, skin, and muscles, anti-seizure drugs, antidepressants, corticosteroids, and opioids. Long-term changes include muscle wasting, trophic skin changes, decreased bone density, decreased proprioception, loss of muscle strength from disuse, and joint contractures. Diagnostic tests utilized? None. Clinical examination will assist in confirming diagnosis. And I already read the physical therapy goals, outcomes, and interventions. Client education for injury prevention. Desensitization activities that focus on return to work activities. Flexibility exercises and TENS for pain relief. And this was out of the pathology book. I added it in. Here's another one. Complex regional pain syndrome, progressive clinical stages. You have stage 1, acute inflammation. Denervation and sympathetic hypoactivity begins up to 10 days following injury and lasts 3 to 6 months. You're going to have pain, more severe than expected, burning or aching character, increased by dependent position, physical contact, and emotional disturbances. Hyperalgesia, allodynia, hyperpathia, edema, vasomotor thermal changes, skin, hypothermia, and dry, increased hair and nail growth. Stage 2 is dystrophic. Paradoxic sympathetic hyperactivity occurs 3 to 6 months after onset of pain and lasts about 6 months. You're going to have pain, worsens, constant burning and aching. Allodynia, all stimuli are perceived as pain. Hyperalgia, lower pain threshold, increased sensitivity. And hyperpathia, pain is threshold to pain is increased. Once extended, sensation intensity increased more rapidly and greater than expected. You're going to have edema, become thicker and more fibrotic, causing joint stiffness. Vasomotor thermal changes, neither warm nor cold. Skin thin, glossy, cool, and sweaty. Thin, rigid nails. X-rays reveal disuse, osteoporosis, cystic, and subchondral bone erosion. Stage 3, atrophic. Begins about 6 to 12 months after onset, may last for years, or may resolve and recur. Pain. It spreads proximally, occasionally the entire skin surface or plateaus, and joint stiffness progresses. Edema continues to harden. Vasomotor thermal changes, sympathetic nervous system regulation is decreased on affected extremity, affected limb is cooler. The skin is thin, shiny, cyanotic, and dry. Fingertips and toes on involved extremity are atrophic. Fascia is thickened. Contractures may occur. X-rays demonstrate bony demineralization and ankylosis. Paget's disease. Etiology is largely unknown, but thought to be linked to a type of viral infection along with environmental factors. Considered to be a metabolic bone disease involving abnormal osteoclastic and osteoblastic activity. Results in spinal stenosis, facet arthropathy, and possible spinal fracture. Primary medical intervention is drug therapy, such as acetaminophen for pain control. Drugs such as calcitonin and ethydronate disodium may be beneficial since they limit osteoclast activity. Diagnostic tests utilize plain film imaging, identifies bone changes. Lab tests look for increased levels of serum alkaline phosphatase and urinary hydroxyproline. Clinical examination assists in confirming diagnosis. Physical therapy goals, outcomes, and interventions include joint bone protection strategies should be taught to patients. Maintain improved joint mechanics and connective tissue functions, and implement aerobic capacity, endurance conditioning, or reconditioning, such as aquatic programs. Torticollis. Spasm and or tightness of the sternocleidoid mastoid muscle in varied etiology. Dysfunction observed is side bending toward and rotation away from the affected sternocleidoid mastoid. So side bending toward and rotation away. Medications, acetaminophen, muscle relaxants, and or NSAIDs. There are no diagnostic tests. Physical therapy goals, outcomes, and interventions include flexibility exercises, manual therapy, soft tissue massage techniques, joint oscillations to reduce pain and or muscle guarding. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Lower extremity conditions, hip conditions, avascular necrosis of the hip, multiple etiologies resulting in an impaired blood supply to the femoral head. Hip range of motion is decreased in flexion, internal rotation, and abduction. So flexion, internal rotation, and abduction. Flexion, internal rotation, and abduction. Hip range of motion is decreased in flexion, internal rotation, and abduction. The diagnostic tests utilized include plain film imaging, bone scans, CT, or MRI. Symptoms include pain in the groin and or thigh, and tenderness with palpation at the hip joint. Coxalgic gait. Coxalgic gait. What does that look like? Medications. Acetaminophen for pain. NSAIDs for pain and or inflammation. Corticosteroids. Contraindicated since they may be causative factor. So corticosteroids are contraindicated since they may be the causative factor. Patients taking steroids for some other condition should have dose decreased. Physical therapy goals, outcomes, and interventions include joint bone protection strategies, maintain improved joint mechanics and connective tissue functions, aerobic capacity, endurance conditioning. Post-surgical intervention includes regaining functional flexibility, improving strength, endurance, and coordination, and gait training. So I'm going to take a pause here and see if I can find a video on coxalgic gait. Please hold. Okay, I found one video. Let's look at this real quick. And then it's blurry, and then it gets turned on its side. But the first lady here is pretty good. I see her too much. Alright, so go back to the PowerPoint. So that's what coxalgic gait. So it looks like we're going to have to really focus on pain reduction first to get the patient to be able to walk normally. Pain is probably influencing that gait pattern for sure. Coxa vara and coxa valga. Angle of femoral neck with shaft of femur is less than 115. Coxa vara results. Angle of femoral neck with shaft of femur is greater than 125. Coxa valga results. Coxa vara usually results from a defect in ossification of the head of the femur. Coxa vara and coxa valga may result from necrosis of the femoral head occurring with septic arthritis. Diagnostic tests utilize plain film imaging. Physical therapy goals include maintain and improve joint mechanics and connective tissue functions. Probably that's the only one on there. Alright, let me see if I can find us a picture. Okay, so angle of inclination, normal angle. Okay. And then with coxa vara, it is less than 115 degrees. So that looks like 90 degrees. Okay. So with coxa vara, it's going to angle the femur bone end at the distal end of the bone, which is going to cause genu valgum. So coxa vara leads to genu valgum. And then coxa valga over here is abnormal increased angle of inclination, which is greater than 125 degrees. Okay. And coxa valga is going to influence genu varum, okay, which is bow-legged. Bow-legged, genu valgum is knock-knees. So they're opposite. Coxa valga causes genu varum, coxa vara causes genu valgum. Okay. Trochanteric bursitis, an inflammation of deep trochanteric bursa from a direct blow. Let's get this on here. Irritation by iliotibial band and biomechanical gait abnormalities causing repetitive microtrauma. This condition is common in patients with RA. There are no diagnostic tests. Diagnosis made by clinical examination differentiate from contractile condition by comparing results of active range of motion, passive range of motion, and resistive testing. Medications include acetaminophen for pain and NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions. Refer to the intervention for general bursitis and tendonitis and tendinosis. Trochanteric bursitis. Iliotibial band tightness friction disorder. Etiology: tight ITB, abnormal gait patterns, results in inflammation of trochanteric bursa. Tight IT band can also come from weak glutes. Noble compression test is positive when pressure with the thumb is introduced over the lateral femoral condyle during the extension. Ober's test will also demonstrate tightness in ITB. So, Ober, Nobles, and Obers. Medications: acetamin for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions include reduction of pain and inflammation, utilizing modality soft tissue techniques, immunotherapy techniques such as soft tissue massage and joint oscillations, correction of muscular imbalances and biomechanical faults using strengthening, endurance, coordination, and flexibility exercises to regain restoration of normal function. IT band, hamstrings, quads, and hip flexors. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization, gait training, and patient education regarding the selection of running shoes and running surfaces. Orthosis may be fabricated. Piriformis syndrome. Piriformis muscle is an external rotator of the hip at less than 60 degrees of hip flexion. It can become overworked with excessive pronation of the foot, causing abnormal femoral internal rotation. At 90 degrees of hip flexion, the piriformis becomes an internal rotator and abductor of the hip. Consider a tonic muscle that is active with motion of sacroiliac joint, particularly the sacrum. So let's go over that again. The piriformis muscle is an external rotator of the hip at less than 60 degrees of hip flexion and can become overworked with excessive pronation of the foot, causing abnormal femoral internal rotation. So like when a patient is walking, the hip is at less than 60 degrees of hip flexion. So the piriformis is an external rotator. It can become overworked with excessive pronation of the foot, which is causing the hip to go into internal rotation. At 90 degrees of hip flexion, the piriformis becomes an internal rotator and abductor of the hip. So when the hip is at a 90-degree angle, the piriformis is an internal rotator and an abductor. It's considered a tonic muscle that is active with motion of the sacroiliac joint, particularly the sacrum. Tightness or spasm of the piriformis muscles can result in compression of the sciatic nerve and or sacroiliac dysfunction. Diagnostic tests utilized, possibly electrodiagnostic tests for sciatic nerve. Symptoms and signs include restriction in internal rotation, pain with palpation of the piriformis muscle, referral of pain to the posterior thigh, weakness in external rotation, positive piriformis test, and uneven sacral base. Perform lower extremity biomechanical examination to determine if abnormal biomechanicals biomechanics are the cause. Must rule out involvement of lumbar spine and or sacroiliac joint. Medications: acetaminophen for pain, NSAIDs for pain and or inflammation, Neurontin for neuropathic pain. Physical therapy goals, outcomes, and interventions include reduction of pain utilizing modalities and immunotherapy techniques such as soft tissue massage to the piriformis muscle, joint oscillations to hip and pelvis to inhibit pain, correction of muscle imbalances and biomechanical faults using strengthening, endurance, coordination, and flexibility exercises to gain restoration of normal function. Restore muscle balance and patient education regarding protection of the SI joint, instruction not to step off a curve into the dysfunctional lower extremity, onto the dysfunctional lower extremity. Correction of biomechanical faults may include orthosis or orthotic devices for the feet. Restore muscle balance and patient education regarding protection of the sacroiliac joint. For example, instructing not to step off a curb onto the dysfunctional lower extremity. Knee conditions: ligament sprains, see Appendix 1G. 4 major ligaments may be involved: ACL, PCL, MCL, and LCL. Injury to the ligaments may result in a single plane or rotary instability. ACL laxity may result in single plane anterior instability. PCL laxity may result in single plane posterior instability. ACL and MCL laxity may result in anterior medial rotary instability. ACL and LCL laxity may result in anterior lateral rotary instability. PCL and MCL laxity may result in posterior medial rotary instability. PCL and LCL laxity may result in posterior lateral rotary instability. Classification of injury: first degree, resulting in little or no instability. Second degree, resulting in minimal to moderate instability. Third degree, resulting in extreme instability. Unhappy triad includes injury to the MCL, ACL, and the medial meniscus, resulting from a combination of valgum, flexion, and external rotation forces applied to the knee when the foot is planted. Diagnostic tests utilized the MRI. It's difficult to visualize complete ACL on MRI, so often read incorrectly as partially torn, even if normal. Refer to knee special tests to help to identify ligamentous instabilities of knee joint. Reconstruction frequently involves a combination of intra-articular and extra-articular procedures. Medications: acetaminophen for pain, NSAIDs for pain and or inflammation. So I'm going to go find us a picture. Okay, I went and got us some pictures of the unhappy triad. See the ACL, the medial meniscus, and the medial collateral ligament there. Resulting from a combination of valgum, flexion and external forces applied to the knee when the foot is planted. So knee flexion, knee valgus, and external forces, external rotation forces of the knee. Let's see. Find a good picture of that. Here's kind of one. So knee flexion, knee valgus, and external rotation forces of the knee. Let's do this one. I like this one. So we got knee flexion, knee valgus, and external rotation forces of the knee. Yep. I'm recording. Okay, so we'll put that in our PowerPoint. Let's go ahead and duplicate that slide. And we'll delete that one. We'll delete that one. I will add it. Unhappy triad. I like that picture. Yep. So the knee is flexed. The knee is in valgus position and external rotation forces. What's going to cause that unhappy triad? All right. Physical therapy goals. Oh, I could have put it there, huh? Now let's do that. Okay. Delete that. Okay. No. Not what I wanted to do, dude. Delete. There we go. Okay. So we got the unhappy triad there. And then the physical therapy goals are intervention is varied depending on whether the patient undergoes a surgical procedure as well as type of surgery performed. Reduction of pain and inflammation utilizing modalities, soft tissue techniques, and manual therapy techniques such as oscillations. Postoperatively continuous passive motion, CPM devices may be used to promote flexibility of the joint, correction of muscle imbalances and biomechanical faults, using strengthening, endurance, coordination, and flexibility exercises to regain restoration of normal function. Biomechanical faults caused by joint restriction should be corrected with joint mobilization, progression to functional training based on patient's occupation and or recreational goals. Meniscal injuries, see Appendix 1C, result from a combination of forces to include tibiofemoral joint flexion, compression, and rotation, which places abnormal shear stresses on the meniscus. So combination of tibiofemoral joint flexion, compression, and rotation. Symptoms include lateral and or medial joint pain, effusion, joint popping, knee giving way during walking, limitation in flexibility of knee joint, and joint locking. So when you do your patient interview, you are looking for a patient to complain of lateral or medial joint pain, swelling, the joint is popping, the knee is giving way when I'm walking, I can't bend my knee, inflexibility of the knee joint. It's usually bending and the joint is locking, popping, locking, giving way, popping, locking, giving way. That's when you want to think of meniscal injury. Diagnostic test utilizes MRI, typically done, but not always sensitive enough to confirm tear. Clinical examination include the following special tests: McMurray's test and Apley's. Medications: acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals include reduction of pain and inflammation utilizing modalities, soft tissue massage techniques to surrounding muscles, and manual therapy techniques such as joint oscillation to inhibit pain. Correction of muscular imbalances and biomechanical faults using strengthening, endurance, coordination, and flexibility exercises to gain restoration of normal function. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization. Progression to functional training based on patient's occupation and or recreational goals. So the meniscal injuries are caused by tibiofemoral joint flexion, compression, and rotation, which places abnormal shear stresses on the meniscus. Okay, I even got a couple of pictures for you guys. Trying to refresh your memory with the Apley's and the McMurray's test. Okay, patellofemoral condition. Smaller. Okay. Abnormal patella positions. Patella alta. Malalignment in which patella tracks superiorly and femoral intracondylar notch may result in chronic patellar subluxation. Positive camel back sign. 2 humps over anterior knee region instead of typical 1. 2 bumps, since patella rides high within femoral condyles, creating a superior bump with tibial tuberosity forming second bump inferiorly. Patella baja. Malalignment in which patella tracks inferiorly in femoral intracondylar notch results in restricted knee extension with abnormal cartilaginous wearing resulting in degenerative joint disease. Lateral patellar tracking can result if there is an increase in the acute angle with a tendency for lateral subluxation or dislocation. Diagnostic tests utilized: plain film imaging, including sunrise view. Physical therapy goals, outcomes, and interventions: regaining functional strength of structures surrounding the knee, particularly the vastus medialis oblique muscle, VMO, regaining normal flexibility of ITB and hamstrings, orthosis if appropriate, and patellar bracing and taping. So let's go get some pictures. Okay, so I went and got some pictures. The patella alta, malalignment in which patella tracks superiorly in femoral intracondylar notch, so it's superior. Patella baja, malalignment in which the patella tracks inferiorly in femoral intracondylar notch. So A is superior to B. I guess that's one way you could remember that the alta, A coming before B, is superior, and the B coming after A is inferior. So patella alta, patella baja. So with the patella alta, you're going to see a camelback sign, 2 humps over the anterior knee region instead of a typical 1. And this picture down here on your right is showing that you would have the knee in a 30 degrees of flexion, and you would see 2 humps instead of 1. So the 2 bumps, since the patella rides high within the femoral condyles, create a superior bump with the tibial tuberosity forming the second bump inferiorly. Okay. Patella baja results in restricted knee extension with abnormal cartilaginous wearing and resulting in disc degenerative disc disease. Lateral patellar tracking could result if there is an increase in the Q angle. And the way you measure the Q angle with the bony, your one arm is going to be lined up with the anterior superior iliac spine, the ASIS, to the midpoint of the patella. The second line is going to be the tibial tubercle to midpoint of patella, and that is your Q angle. So anterior superior iliac spine to the midpoint of the patella, tibial tubercle to the midpoint of the patella. And that is your Q angle. So here is the typical tubercle right here. Here's the midpoint of the patella. And here's your ASIS. And that's going to measure your Q angle. The greater the Q angle, the greater the tendency to move the patella laterally against the femoral condyle. A large Q angle plus strong quad contraction can dislocate the patella. The diagnostic tests utilized plain film imaging include the sunrise view, and this is how the sunrise view is done in this position here. Okay, patellofemoral pain syndrome. Common dysfunction that may occur on its own or in conjunction with other etiologies. May be caused by trauma or by congenital developmental dysfunction. May be interrelated with chondromalacia, patella, and or patella tendinitis. Common result is an abnormal patellofemoral tracking leading to abnormal patellofemoral stress. Occasionally, surgery is indicated. Diagnostic tests include possibly an MRI to rule out other dysfunctions. Medications include acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions. Patellofemoral mecanal taping is helpful to inhibit pain during rehabilitation. Patella mobilization indicated with restrictions of patella glides. For example, if patella is in a lateral glide position and has decreased medial glide, perform a medial glide joint mobilization to the patella. Correction of muscle imbalances and biomechanical faults using strengthening, endurance, coordination, and flexibility exercises to regain restoration of normal function. Don't use quad sets, single leg raise flexion, and isolated quadricep exercises for patellofemoral pain. Don't use quad sets, single leg raise, straight leg raise, and isolated quadricep exercises for patellofemoral pain. Patella mobilization indicated with restrictions of patella glides. If patella is in a lateral glide position and has decreased medial glide, they form a medial glide joint lobe to the patella. Patellar tendinosis and tendinopathy. Jumper's knee. This is a degeneration condition of the patellar tendon, typically of a deep aspect of the tendon. May be related to overload and or jumping related activities and sports. May also be interrelated with patellofemoral dysfunction. Diagnosis made by clinical examination, medications, acetaminophen for pain, NSAIDs for pain and or inflammation, cortisone injection or by mouth. Physical therapy goals, outcomes, and interventions. Refer to intervention for general tendinopathy and tendinitis. Hez and serine bursitis. That's interesting. That kind of cough in there. Typically caused by overuse or a contusion, must be differentiated from tendinitis. Diagnosis made by clinical examination. Differentiate from contractile condition by comparing results of active range of motion, passive range of motion, and resistive test. Medications, acetaminophen for pain, NSAIDs for pain and or inflammation, cortisone injection by mouth, physical therapy goals, outcomes, and interventions. It looks like I missed something. Please hold. Okay, now I went back to the PDF, and nope, that's all there was for that one. Okay, fractures involving the knee joint. Femoral condyle. Medial condyle most often involved due to its anatomical design. Numerous etiology factors include trauma, shearing, impacting, and avulsion forces. Common mechanism of injury is a fall with knee subjected to a shearing force. Tibial plateau. Common mechanism of injury is a combination of valgum and compression forces to knee when knee is in a flexed position. Combination of valgum and compression forces to knee when knee is in a flexed position. Often occurs in conjunction with a medial lateral ligament injury, in conjunction with the MCL injury. Epithelial plate mechanism of injury is frequently a weight-bearing torsional stress. Presents more frequently in adolescents, where an ACL injury would occur in an adult. Patella. Most common mechanism of injury is a direct blow to the patella due to a fall. Diagnostic tests utilize plain film imaging most likely, and less complex fracture, which would benefit from a CT. Medications, acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions emphasizes return to function without pain. So you have the femoral condyle, the tibial plateau, and the epithelial plate. Oops. Okay, conditions of the lower leg, anterior compartment syndrome. Increased compartmental pressure resulting in a local ischemic condition. Multiple etiologies include direct trauma, fracture, overuse, and or muscle hypertrophy. Symptoms of chronic or exertional compartment syndrome are produced by exercise or exertion and described as deep cramping feeling. Symptoms of acute anterior compartment syndrome are produced by sudden trauma, causing swelling within the compartment. Diagnosis made by clinical examination. Acute anterior compartment syndrome is considered a medical emergency and requires immediate surgical intervention with fasciectomy. Anterior tibial peritonitis, shin splints. Musculotendinous overuse injury. Three common etiologies: abnormal biomechanical alignment, poor conditioning, improper training methods. Muscles involved include anterior tibialis and extensor hallucis longus. Extensor hallucis longus. Pain elicited with palpation of lateral tibia and anterior compartment. Diagnosis made by clinical examination. Medications, acetaminophen for pain, NSAIDs for pain and or inflammation, physical therapy goals, outcomes, and interventions, correction of muscle imbalances and biomechanical faults using strengthening, endurance, and coordination exercises, flexibility exercises for anterior compartment muscles, as well as triceps serrae to regain restoration of normal function. Okay, so the contents of the interfascial compartment of the leg include the tibialis anterior, the extensor digitorum longus, the extensor hallucis longus, and the peroneus tertius. So flexibility exercises for the anterior compartment muscles as well as the triceps serrae to gain restoration of normal function. And triceps serrae is there. Gastroisoleus. All right, medial tibial stress syndrome, overuse injury of the posterior tib and or medial soleus, resulting in periosteal inflammation at the muscular attachments. Etiology is thought to be excessive pronation. Pain elicited with palpation of the distal posterior medial border of the tibia. Diagnosis made by clinical examination. Medications, acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes, and interventions. Correction of muscle imbalances and biomechanical faults using strengthening, endurance, and coordination exercises. Flexibility exercises for anterior compartment muscles, as well as triceps serrae to regain restoration of normal function. Okay, found us a picture, medial tibial stress syndrome, overuse injury of the posterior tib, right here, posterior tib, and the medial soleus. So it's going to be the medial soleus muscle, resulting in periosteal inflammation at the muscular attachments. Etiology is thought to be excessive pronation, and the physical therapy goals and interventions would be flexibility exercises for the anterior compartment as well as the triceps. So basically the same here as the anterior tibial peritonitis. Stress fractures. Overuse injury resulting most often in microfracture of the tibia or fibula. 49% of all fractures involve the tibia and 10% involve the fibula. Three common etiologies: abnormal biomechanical alignment, poor conditioning, and improper training methods. Diagnostic test, plain film imaging, and bone scan. Acetaminophen for pain, NSAIDs for pain and or inflammation. Physical therapy goals, outcomes and interventions, correction of muscular imbalances and biomechanical faults, using strengthening endurance and coordination exercises, flexibility exercises for the anterior compartment as well as the triceps raise. So basically going back up here, contents of the anterior fascial compartment of the leg, which is the tibialis anterior, extensor digitorum longus, extensor hallucis longus, hallucis longus, peroneus tertius, and the triceps rae is the gastroc and soleus. So, if you have anterior tibial peritonitis, shin splints, medial tibial stress syndrome, or stress fractures, you're going to focus on strengthening the compartments of the anterior compartment of the leg, as well as the triceps, front and the back. So toe raises and heel raises, pretty much. Okay, ankle and foot conditions. Ligament sprains. 95% of all ankle sprains involve lateral ligaments. 95% of all ankle sprains involve lateral ligaments. With lateral sprains, the foot is plantar flexed and inverted at the time of the injury. Plantar flexed and inverted. The most common grading system is as follows. Get down, Jenny. Get down. Quit barking. Grade 1. No loss of function with minimal tearing of the anterior talofibular ligament. Grade 2. Loss of some function with partial disruption of the anterior talofibular and calcaneofibular ligaments. And grade 3. Complete loss of function with complete tearing of the anterior talofibular and calcaneofibular ligaments with partial tear of the posterior talofibular ligament. Diagnostic test is an MRI if necessary. Inability to instability. Instability is evaluated using the anterior drawer and Taylor tilt special test. Medications, acetaminophen for pain, NSAIDs for pain and inflammation. Therapy goals, outcomes, interventions. Physical therapy intervention is varied depending on whether the patient undergoes a surgical procedure as well as type of surgery that is performed. Reduction of pain and inflammation utilizing modalities, soft tissue techniques, and manual therapy techniques such as oscillations. Correction of muscle imbalances and biomechanical faults using strengthening, endurance, coordination, and flexibility exercises to gain restoration of normal function. Biomechanical faults caused by joint restrictions should be corrected with joint mobilization to the specific restrictions identified during the examination. Progression to functional training based on patient's occupation and or recreational goals. Okay, so sprained ankle grading. So the grade 1, grade 2, and grade 3. Let's see, I want to read. Let's go ahead and snip that out of here. Control C, go here. Move that over and move this over here. Okay. So grade 1 is no loss of function with minimal tearing of the anterior talofibular ligament. So that's going to be the ligament in yellow. Grade 2 is some loss of function with partial disruption of the anterior talofibular and calcaneofibular ligaments. That's going to be the yellow and the red ligaments, as you can see in the picture, grade 2 picture. Grade 3 is complete loss of function with complete tearing of the anterior talofibular and calcaneofibular ligaments. Look at the picture in grade 3 right here. Complete tearing here, and a partial tear of the posterior talofibular ligament. So grade 1, no loss of function, minimal tearing of the anterior talofibular ligament. Grade 2, some loss of function, partial disruption of the anterior talofibular and the calcaneofibular ligaments. In grade 3, complete loss of function, complete tearing of the anterior talofibular and the calcaneofibular ligaments, and partial tear of the posterior talofibular ligament. Another picture. So inversion, so like the slide before said, plantar flexion and inversion, lateral sprain is the most common, being 85% of all ankle sprains involving the lateral ligaments. So there you go. So grade 1, you're going to have minimal tenderness and swelling. Grade 2, moderate tenderness and swelling, decreased range of motion, possible instability. Grade 3, significant swelling and tenderness and instability. The 2 test is the anterior drawer and the Taylor tilt test. Anterior drawer and the Taylor tilt test. All right. Achilles tendinosis tendinopathy, see Appendix 2. This is a degeneration condition of the Achilles tendon. Clinical examination, including Thompson's test, helps to identify this condition. Medications, acetaminophen for pain, NSAIDs for pain and or inflammation, corticosteroid injection or by mouth. Physical therapy goals, outcomes, and interventions refer to intervention for general bursitis, tendinitis, tendinosis. Let's go find a picture of the Thompson's test. Okay, let's go back instead of going to all of my test for Achilles. And there we go. Basically, you're just squeezing the calf muscle. Here's one. Squeezing the calf muscles cause them to contract. Thus, plantar flexion will occur. If no plantar flexion occurs, the Achilles tendon is ruptured. So that is the Thompson test. Here we go. All right, moving on. Fractures of the foot and ankle. Unimalleolar involves the medial or lateral malleolus. Bimalleolar involves the medial and lateral malleola. Trimalleolar involves the medial and lateral malleoli and the posterior typical of the distal tibia. Diagnostic tests utilized: plain film imaging. Growth plate fractures are a concern since bone growth can be affected. Types 3 and 4 fractures, according to the Slaughter-Harris classification, are the most concerned and can have a high complication rate. Acetaminophen for pain, NSAIDs for pain and or inflammation, Physical therapy goals, outcomes, and interventions. Physical therapy intervention emphasize return to function without pain. Functional training and restoration of muscles imbalances using exercise to normalize strength, endurance, coordination, and flexibility. Early passive range of motion is important in preventing capsular adhesions. This for a second. Okay, so a unimanular fracture is going to involve the medial or lateral. Bimanular is going to involve the medial and lateral. Here, this is how they fix it. And the trimanular involves the medial lateral and the posterior tubercle of the distal tibia. Posterior tubercle of the distal tibia. And again, growth plate fractures are a concern since the bone growth can be affected. Types 3 and 4 fractures are the most concerned and have a high complication rate. Tarsal tunnel syndrome. Entrapment of the posterior tibial nerve or one of its branches within the tarsal tunnel. Over excessive pronation, overuse problems resulting in tendinitis of the long flexor and posterior tibialis tendon. And trauma may compromise space in the tarsal tunnel. Symptoms include pain, numbness, and paresthesia along the medial ankle to the plantar surface of the foot. Diagnostic tests utilized: electrodiagnostic tests, positive Tinel sign at the tarsal tunnel, medications, acetaminophen for pain, NSAIDs for pain and or inflammation, Neurontin for neuropathic pain. Physical therapy goals, outcomes, and interventions include use of orthosis to maintain neutral alignment of the foot. If abnormal neurotension is present, neurodynamic mobilization may be indicated. Okay, so got a few pictures, like this one up here in the top right-hand corner up here. The posterior tibial tendon, posterior tibial nerve, going underneath the flexor retinaculum right there. And that's the tunnel. And then the tarsal tunnel syndrome test is the positive is a Tinel sign. So tapping on the nerve causes radiation of pain into the medial side of the ankle and possibly the foot. Okay, flexor hallucis tendinopathy, identified as tendinosis in the acute stage or can present as a chronic tendinosis. Commonly seen in ballet performers. Acetaminophen for pain, NSAIDs for pain and inflammation, corticosteroid injection or by mouth. Physical therapy goals, outcomes, interventions refer to intervention for general bursitis, tendinitis, and tendinosis. Vascavis, hollow foot. Numerous etiologies to include genetic predisposition, neurological disorders resulting in muscle imbalances and contracture of soft tissue. Deformity observed includes an increased height in longitudinal arches, dropping of anterior arch, metatarsal heads lower than hindfoot, plantar flexion, and splaying of forefoot and claw toes. Function is limited due to altered arthrokinetics, reducing ability to absorb forces through foot. Diagnosis made by clinical examination, including thorough biomechanical lower quarter exam. Physical therapy goals, outcomes, and interventions. Intervention includes patient education, emphasizing limitation of high-impact sports, long-distance running, and ballet, use of proper footwear, and fitting for orthosis. Okay, so Deformity observed includes an increased height of longitudinal arches, dropping of the anterior arch. Metatarsal heads are lower than the hindfoot, and plantar flexion and splaying of forefoot and claw toes. Equinus. Etiology can include congenital bone deformation, neurological disorders such as cerebral palsy, contracture of gastroc and or soleus muscles, trauma, or inflammatory disease. Deformity observed, plantar flex foot. Compensation secondary to limited dorsiflexion includes subtalar or mid-tarsal pronation. Diagnosis made by clinical examination, including thorough biomechanical lower quarter exam. Physical therapy goals, outcomes, and interventions include flexibility exercises of shortened structures within foot, joint mobilization to joint restrictions identified in examination, strengthening to intrinsic and extrinsic foot muscles, and orthotic management. Okay, so deformity observed would be a plantar flex foot. Right here. And compensation secondary to limited dorsiflexion includes subtalar or mid-tarsal pronation. Hallux valgus. Etiology is varied to include biomechanical malalignment, excessive pronation, ligament laxity, hereditary, weak muscles, and footwear that is too tight. Deformity observed, the medial deviation of the head of the first metatarsal from midline of body. Metatarsal and base of proximal first phalanx move medially, while distal phalanx then moves laterally. Normal metatarsophalangeal angle is 8 to 20 degrees. Diagnosis made by clinical examination, including thorough biomechanical lower quarter exam. Physical therapy goals, outcomes, and interventions, early orthotic fitting and patient education. Later management requires surgery, followed by flexibility exercises to restore normal function, strengthening exercises, and possible joint mobilization to identify restrictions. Okay, so deformity observed, medial deviation of head of first metatarsal from midline of the body. So the first metatarsal from midline of the body, medial deviation. So we have 2 feet together. This right here would be a medial deviation of the first metatarsal from the midline of the body. Metatarsal and base of proximal first phalanx move medially. Base of the first phalanx, while the distal phalanx then moves laterally. And that's hallux valgus. Normal here is less than 15 degrees. Mild is less than 20. Moderate is 20 to 40, and severe is greater than 40 degrees. Metatarsalgia. Etiologies: mechanical, tight triceps serrae group and or Achilles tendon, collapse of transverse arch, short first ray, pronation of forefoot. Structural changes in transverse arch, possibly leading to vascular and or neurocompromise in tissues of forefoot. Changes in footwear. Complaint frequently heard is pain at first and second metatarsal heads after long periods of weight bearing. Diagnosis made by clinical examination, including thorough biomechanical lower quarter exam. Medications: acetaminophen for pain, NSAIDs for pain and or inflammation, Neurontin for neuropathic pain. Physical therapy goals, outcomes, and interventions include correction of biomechanical abnormality, improving the flexibility of the triceps serrae, modalities to decrease pain, prescription and or creation of orthoses, patient education regarding selection of footwear. Okay, so here we have some pictures of the metatarsal pain in the region of one or more of the metatarsal heads. Morton's neuroma is one cause of metatarsalgia. Structural changes in the transverse arch. The picture in the bottom, transverse arch. Possibly leading to vascular and or neurocompromise in tissues of the forefoot. A short first ray and pronation of the forefoot. So interventions include correcting the biomechanics abnormality, improving flexibility in the gastroc and soleus, and modalities to decrease pain. Okay. Charcot-Marie tooth disease. Perineal muscular atrophy that affects motor and sensory nerves. May begin in childhood or adulthood. Initially affects muscles in lower leg and foot, but eventually progresses to muscles of hands and forearm. Slowly progressive disorder with varying degrees of involvement depending on degree of genetic dominance. Diagnostic tests utilized are the electrodiagnostic test. Diagnosis is made by clinical examination, including thorough biomechanical lower quarter exam. Medications: acetaminophen for pain, NSAIDs for pain and or inflammation, Neurontin for neuropathic pain. Physical therapy goals, outcomes, and interventions include no specific treatment to prevent, since it is an inherited disorder. Physical therapy intervention centers on preventing contractures, skin breakdown, and maximizing patients' functional capacity to perform activities. Patient education and training regarding braces and ambulatory assistive devices. Okay, and so I went and found some pictures, of course, of the perineal muscular atrophy that affects motor and sensory nerves. And I've actually seen patients with this. It's kind of sad. But anyway, let's move on. Plantar fasciitis. Etiology is usually mechanical. Chronic irritation of plantar fascia from excessive pronation. Limited range of motion of first metatarsal phalangeal and talocrural joint. Tight triceps serrae, which is the gastroc soleus. Acute injury from excessive loading of foot. Rigid cavus foot. Results in micro tears at attachment of plantar fascia. Diagnostic tests utilized none. Diagnosis made by clinical examination, including thorough biomechanical lower quarter exam. Differentiated from tarsal tunnel syndrome by a negative Tunnell sign. Medications: acetaminophen for pain, NSAIDs for pain and or inflammation, cortisone injection by the mouth or by mouth. Physical therapy goals, outcomes, and interventions include regaining proper mechanical alignment, Modalities to reduce pain and inflammation. Flexibility of the plantar fascia for the pes cavus foot. Careful flexibility exercises for the triceps surae, which are the gastrocnemius. Joint mobilization to identify restrictions. Night splints. Strengthening of inverters of foot. Strengthening of inverters of foot. Patient education regarding selection of footwear and orthotic fitting. Forefoot, rear foot deformities. Rear foot, subtalar varus, calcaneal varus. Etiology, abnormal mechanical alignment of tibia. Shortened rear foot soft tissues, or malunion of calcaneus. Deformity observed, rigid inversion of calcaneus when subtalar joint is in neutral position. Diagnosis made by clinical examination, including thorough biomechanical lower quarter exam. Physical therapy goals. Outcomes and interventions, regaining proper mechanical alignment, improving flexibility of shortened soft tissue, orthotic fitting, and patient education regarding selection of footwear. Okay, so here's a picture of rear foot valgus and rear foot varus. Talking about varus, so subtalar varus, calcaneal varus. Over here on the right. This is a positional deformity where the entire foot is inverted relative to the ground when the subtalar joint is in its neutral position, as shown here. So this is uncompensated here. So the subtalar joint here is in neutral position, but the rear foot varus, see the angle? So compensation is made when the foot is on the ground and weight bearing. Notice what happens to the subtalar joint, which so rear foot valgus. So we'll go ahead and copy the picture and bring it down here. Rear valgus, etiology, abnormal mechanical alignment of the knee, genu valgum, or tibial valgus. Deformity observed, eversion of the calcaneus with the neutral subtalar joint due to increased mobility of the hindfoot. Fewer musculoskeletal problems develop from this deformity than with rear foot varus. Diagnosis made by clinical examination, including thorough biomechanical lower quarter exam. Physical therapy goals, outcomes, and interventions, regaining proper mechanical alignment, improving flexibility of shortened soft tissues, orthotic fitting, and patient education regarding selection of footwear. Okay, so rear foot, forefoot deformities, rear foot varus. Over here on the right, abnormal mechanical alignment of tibia, shortened rear foot soft tissues, or malalignment of calcaneus. Deformity observed, rigid inversion of calcaneus when subtalar joint is in neutral position. So in this picture, you see uncompensated rear foot varus. And then when it's compensated in weight bearing, see what happens to the subtalar joint. Rear foot valgus, abnormal mechanical alignment of the knee, genu valgum, or tibial valgus. So here you see valgus stress at the knee. rear foot valgus here. So you have the arch collapsing with rear foot valgus. Like here, rear foot valgus. So the arch, lowering of the arch, the rear foot is in eversion. Like what happens to the knee. The knee goes into a valgus stress. So deformity observed is eversion of the calcaneus with a neutral subtalar joint. Eversion of the calcaneus. Go ahead and copy this and move it. I like that picture. Get that picture out of one of our books. Okay. So, again, eversion of the calcaneus, rear foot eversion, right here, okay, and with a neutral subtalar joint. So if the subtalar joint is neutral, the calcaneus is everted. That's not in weight bearing. In weight bearing, the subtalar joint position changes in weight bearing. Due to increased mobility of hind foot, fewer musculoskeletal problems develop from this deformity than rear foot varus. Up here, rear foot varus. So that's a high arch varus. Rear foot valgus is when the lowering of the arch. Okay, and then you have forefoot varus, congenial abnormal deviation of head and neck of talus. Deformity observed is inversion of forefoot when subtalar joint is in neutral. So it's a congenial abnormal deviation of the head and neck of the talus. Let's find a picture of the head and the neck of the talus. Okay. So here's the talus. You have the head, the neck, and the body of the talus. Oh, it wants to act out today, doesn't it? And okay, bring this down here. My goodness. Act out, doesn't it? Let me pause this and deal with this. What are you doing? Okay, sorry about that. I don't know what was happening with that. I had to shut down the PowerPoint and bring it back up. But where were we? Okay, so forefoot varus is congenial abnormal deviation of head and neck of talus. And so as you see in this picture, I've added the head and the neck of the talus. Then we have forefoot valgus. Again, it's a congenial abnormal development of the head and neck of the talus. So let's go ahead and copy that, and we'll bring it over here. Hey, okay. Deformity observed is eversion of the forefoot when the subtalar joint is in neutral. And then there's the slide from the Kinesiology of Musculoskeletal System ebook, table 14.5. And I'm going to end this. This is a long video. So that will conclude this video. And like I said, later on, I will do another video, some individual videos on the pathologies that it talked about a little bit more in depth. And this was the list of pathologies that they talked about. That's in the Dropbox. And that will be it for Free Stuff Saturday. Review of skeletal and soft tissue conditions and lower extremity conditions. Hour and 45 minutes. See you on the next one.